This is Dr. Lyle Jones, Editor-in-Chief of Continuum, the premier topic-based neurology clinical review and CME journal from the American Academy of Neurology. Thank you for joining us on Continuum Audio, which features conversations with Continuum's guest editors and authors who are the leading experts in their fields. Subscribers to the Continuum Journal can read the full article or listen to verbatim recordings of the article and have access to exclusive interviews not featured on the podcast. Please visit the link in the episode notes for more information on the article, subscribing to the journal, and how to get CME.
Hello, this is Dr. Kait Nevel. Today I'm interviewing Dr. Adriana Bermeo about her article on a multidisciplinary approach to non-epileptic events, which she wrote with Dr. Victor Patron. This article appears in the February 2025 Continuum issue on epilepsy. Welcome to the podcast, and please introduce yourself to our audience.
Hello, Dr. Nevel. It's a pleasure to be here. Thank you very much for inviting me. My name is Adriana Bermeo, and I'm an adult epileptologist at Rush University Medical Center in Chicago. And I am also the co-director of the NET Clinic, which is a treatment clinic for patients with non-epileptic seizures within our Level 4 Epilepsy Center.
Wonderful. Well, thank you so much for being here. And I can't wait to talk to you about your article and learn a little bit about NEST maybe during our conversation and how you approach things. To start us off talking about your article today, could you share with us what you think is the most important takeaway from your article for the practicing neurologist?
Wonderful. There's some messages that I would like people to get from working with patients with functional neurologic disorders in general. The first one is that functional neurologic disorders are very common in presentation in the neurology clinic, almost no matter what your practice or subspecialty care is. The second is that for people who treat patients primarily with seizures or epilepsy, they account for between 5 to 10% of our patients in the clinic, but about 30% of our patients in our epilepsy monitoring unit because the seizures typically do not respond to anti-seizure medication management. Also, that in order to diagnose them, you don't need to have a neuropsychological stressor readily available for the patient or the clinician. And the most important thing is that there are available treatments for these patients and that there are options that we can offer them for them to have less seizures and to be more integrated to whatever activities they want to get integrated.
Wonderful. What do you think a practicing neurologist might find surprising after reading your article?
I think still many neurologists feel very hopeless when they see patients with these conditions. They do not have very good answers right away for the patients, which is frustrating for the neurologist. And they don't think there's too much they can do to help them other than send them somewhere else, which is very difficult for the neurologist and is crushing to the patients to see this doctor that they're hoping to find answers to, and then just find that there's not much to do. But what I want neurologists to know is that we are making strides in our understanding of the condition and that there are effective treatments available. And I hope that after reading this and engaging with this conversation, they will feel curious, even hopeful when they see the next patient in the clinic.
Yeah, absolutely. I find the history of non-epileptic seizures really interesting, and I enjoyed that part of your article. How has our understanding of non-epileptic seizures evolved over the centuries? And how does our current understanding of non-epileptic seizures inform the terminology that we use?
Yeah. The way we name things and the way we offer treatment goes along to how we understand things. So the functional seizures and epileptic seizures were understood in ancient times as possession from the spirits or the demons or the gods. And then treatments were offered to those kind of influences. And that continues to happen with functional seizures. So we go through the era when this was thought to be a women-only condition that was stemming from their reproductive organs, and then treatments accordingly were presented. And later on with Charcot and then Freud, they evolved to even conversion disorders, which is one, understanding them as conversion disorders, which is one of the framework where this condition has been treated with psychotherapy, psychoanalytic psychotherapy. And in our current understanding, we understand functional neurologic disorders in general as a more like a connection, communication network disorder between areas of the brain that modulate emotional processing and movement control. And therefore, our approach these days is much more geared towards rehabilitation. I think that's the evolution of thinking in many different areas. And as we learn more, we will be acquiring more tools to help our patients.
Yeah, great. Thanks so much for that answer. Just reading the historical information that you have in your article, you can imagine a lot of stigma with this diagnosis too over time. And that I think that that's lessening, but I was wondering if you could talk about that a little bit. How do we approach that with our patients and loved ones, any stigma that they might feel or perceive from being diagnosed with non-epileptic seizures?
Thank you for asking that question. Stigma is actually an important problem even for people living with epilepsy. There's still a lot of misunderstanding of what epilepsy is and how it affects people, and that people living with epilepsy can live normal, healthy lives and do everything they want to do with appropriate treatment. And if a stigma is still a problem with epilepsy, it is a huge problem for patients living with functional neurologic symptoms in general, but particularly with functional seizures or non-epileptic seizures. Because the stigma in this population is even perpetuated by the very people who are supposed to help them: physicians, primary care doctors, emergency room doctors. Unfortunately, the new understanding of this condition has not gotten to everybody, and these patients are often even blamed for their symptoms and for the consequences of their symptoms and of their seizures in their family members, in their job environment, in their community. Living with that is really, really crushing, right? Even people talk a lot about malingering. They talk about secondary gain. I can tell you, the patients I see with functional seizures gain nothing from having this condition. They lose often a lot. They lose employment, they lose ability to drive, they lose their agency and their ability to function normally in society. I do think that the fighting of stigma is one that we should do starting from within, starting from the healthcare community into our understanding of what these patients go through and what is causing their symptoms and what can we do to help them. So there's a lot of good work to be done.
Absolutely. And it starts, like you said, with educating everybody more about non-epileptic seizures and why this happens. The neurobiology, neurophysiology of it that you outlined so nicely in your article. I'm going to encourage the listeners to look at figure 1 and 4 for some really nice visualization of these really complex things that we're learning a lot about now. And so if you don't mind, for our listeners, kind of going over some of the neurobiology and neurophysiology of non-epileptic seizures and what we're learning about it.
Our understanding of the pathophysiology of functional neurologic seizure disorder is in its infancy at this point. The neurobiological processes that integrate emotional regulation and our responses to it, both to internal stimuli and to external stimuli, and how they affect our ability to have control over our movement. It's actually amazing that we as neurologists know so little about these very complex processes that the brain do, right? And for many of us, is the reason why we're in neurology, right? To be at the forefront of this understanding of our brain. So this is in that realm. It is interesting what we have learned, but it's amazing all that we have to learn. There is the clear relationship between risk factors. So we know patients with functional neurologic symptom disorder and with functional seizures, particularly in many different places in the world, with many different beliefs, relationship to their body, to their expression of their body, have this condition no matter how different they are. And also we know that they have commonalities, for example, traumatic experiences that are usually either very strong traumatic experiences or very pervasive traumatic experiences or recurrent over time of different quality. So we are in the process of understanding how these traumatic experiences actually inform brain connectivity and brain development that result in this lack of connections between brain areas and the expression of them, and that results in these kind of disorders. I wish I can tell you more about it or that I would understand more about it, but I am just grateful for the work that it's been done so that we can understand more and therefore have more to offer to these patients and their families and their communities that are supported.
Yeah, absolutely. That's always the key, and just really exciting that we're starting to understand this better so that we can hopefully treat it better and inform our patients better and ourselves. Can you talk to us a little bit about the multidisciplinary team approach in taking care of patients with non-epileptic seizures? Who's involved? What does best practice model look like? You have a clinic there. Obviously, if you could share with us how your clinic runs in the multidisciplinary approach for care of these patients.
The usual experience of patients dealing with functional seizures, because this is a condition that has neurological symptoms and psychiatric symptoms, is that they go to the neurologist and the neurologist does not feel sufficiently able to manage all the psychiatric comorbidities of the condition. So the patient is sent to psychiatry. The psychiatry really finds themselves very hopeless into handling seizures, which is definitely not their area of expertise. And these patients end being ping-ponging from one to the other, or they are eventually sent to psychotherapy and the psychotherapist doesn't know what they're dealing with. So we have found and we didn't come up with this. We had wonderful support from other institutions who have been doing this for a longer time, that bringing all of these specialty together and kind of situating ourselves around the patient so that we can communicate our questions and our discrepancies and our decision between who takes care of what without putting that burden on the patient is the best treatment, not only for the patient who finally feels welcomed and not burdened, but actually for the team, so that the psychiatrists and the neurologists support the psychotherapist who does the psychotherapy rehabilitation-minded program. And we also have the support and the involvement of neuropsychology. So we have a psychiatrist, a neurologist, social worker, psychotherapist, and neuropsychology colleagues. And together we look at the patient from everywhere and we support each other in the treatment of the patient, keeping the patient in the middle and the interest of the patient in the middle. And we have found that that approach has helped our patients the best, but more importantly, make our job sustainable so that none of us is overburdened with one aspect of the care of the patient. And we feel supported from the instances that is not our most comfortable area. So that is one model to do it. There's other models how to do it, but definitely the interdisciplinary care is the way to go so far for the care of patients with functional neurologic symptom disorders and with functional seizures or non-epileptic seizures in particular.
Yeah, I can see that everybody brings their unique expertise and then doesn't feel like they're practicing outside their, like you said, comfort zone or scope of practice. In these clinics, or maybe this happens before the patient gets to this multidisciplinary team, when you've established a diagnosis of non-epileptic seizures, what's your personal approach or style in terms of how you communicate that with the patient and their loved ones?
It is important to bring this diagnosis in a positive term. Unfortunately, the terminology question is still out, and there's a lot of teams very invested into how to better characterize this condition and how to being told that you don't have something is maybe not that satisfying for patients. So we are still working on that. But we do deliver the diagnosis in positive terms, like this is what you have. It's a common condition, is shared by these many other people in the world. It's a neuropsychiatric disorder, and that's why we need the joint or collaborative care from neurology and psychiatry. We know the risk factors, and these are the risk factors. You don't have to have all of them in order to have this condition. These are the reasons why we think this is the condition you have. there is coexisting epilepsy and functional seizures as well, we will explore that possibility. And if we get to that conclusion, we will treat these two conditions independently, and our team is able to treat both of them. And we give them the numbers of our own clinic and other similar clinics. And with that, they hope that they will be able to get the seizures under better control and back to whatever is important to them. I tell my trainees and my patients that my goals of care for patients with functional seizures are the same as my patients with epileptic seizures, meaning less seizures, less disability, less medications, less side effects, less burden of the disease. And when we communicate it in that way, patients are very, very open and receptive.
Right. What do you think is a mistake to avoid? I don't know if mistake is necessarily the right word, but what's something that we should avoid when evaluating or managing patients with non-epileptic seizures? What's something that you see sometimes maybe that you think we should do that differently?
Missing the opportunity of engaging with these patients is probably the hardest one, because neurologists have the credibility, they have the relationship, they have, even if they don't have a multidisciplinary team all sitting in one room, they probably have some of the pieces of this puzzle that they can bring together by collaborating. So I think missing the opportunity, telling the patient this is not what I do, or this is not something that belongs to me, you need to go to a mental health provider only, I think is the hardest one and the most disheartening for patients, because our patients come to us just like all patients with hopes and with some information to share with us so that we can help them make sense of it and have a better way forward. We as neurologists know very well that we don't have an answer to all our patients, and we don't offer 0 seizures to any of our patients, right? We offer our collaborative work to understand what is going on and a commitment to walk in the right direction so that we are better every day. And I do think wholeheartedly that that is something that we can offer to patients with functional seizures almost in any environment.
Yeah, absolutely. And using that multidisciplinary approach and being there with your patient moving forward in a longitudinal fashion, I can see how that's so important. What do you find most challenging and what do you find most rewarding about caring for patients with non-epileptic seizures?
I think what I find more challenging are the systemic barriers that the system still places. We discuss with the patients what is the right time to go to the emergency room or not, because the emergency room may be a triggering environment for patients with functional seizures. And it may be a place where not everybody is necessarily attuned to have this conversation. Having said that, I never tell any of my patients not to go to the emergency room because I don't know what's happening with them. As a matter of fact, we're getting a lot of information on high mortality rates in patients with functional seizures, and is not because of suicide and is probably not related to the seizure. Maybe this is speculation on my part, that is because they get to more severe conditions in other things that are not the functional seizures, because they just experience the healthcare system as very hostile, because we are in many instances, is very hostile. So navigating that is a little bit difficult, and I try to tell them to have the doctors call me so that I can frame it in a different way and still be there for them. But I can tell you this clinic is the most rewarding clinic of all my clinical activities, and I love with all my heart being an epileptologist and seeing my patients with epilepsy. But the number of times my patients with functional seizures say, nobody had ever explained this to me, nobody had ever validated my experience in front of my family so that I'm not feel guilty myself for having these episodes. I can't tell you how many times. And obviously, patients who come to the non-epileptic seizure clinic already know that they come to the non-epileptic seizure clinic. So that you can say is a selection of patients that are already educated in this condition to come to the clinic. But I would love everybody to know managing this population can be enormously, enormously satisfying and rewarding.
Especially for, I imagine, patients who have been in and out of the ER, in and out of the hospital, seeing multiple providers and make their way to you, and you're able to explain it in a way that makes sense and hopefully reduces some of that stigma maybe that they had been feeling.
And along with that, iatrogenic interventions, unnecessary intubations, unnecessary ICUs, like so much. And I think I have no superpower to do that other than understanding this condition in a different way. And by I mean all the providers, because I'm not alone in this. There's many, many people doing excellent work in this field, and we just need to be more.
Yeah, sure, absolutely. So on that note, what's next in research, or what do you think will be the next big thing? What's on the horizon in this area?
I think the community in the functional neurologic disorder community is really hopeful that more understanding into the neurobiology of this condition will bring more people over and more neurologists willing to take it over. There was an invitation from the NIH, I think about 4 or 5 years ago, to submit proposals for research in this area in particular. So all of those studies must be ongoing. I'm much more a clinician than a researcher myself, but I am looking forward to what all of that is going to mean for our patients and for, I think there's other opportunities in that. Further understanding of the clinical manifestations of many other conditions, and for our understanding of our relationship with our patients. I feel we are more attuned to align with a disease than with the experience of the patient. And with a disease like this, a condition like this one, we have to engage with the personal experience of the patient. What I mean by that is that we are more likely to say, I'm an epileptologist, I'm an MS doctor, and we engage with that condition. This condition obliges, makes us engaging with the symptom and with the experience of the person. And I think that's a different frame that is real and grounded into the relationship with our patients. So I think there's so much that we can learn that can change practice in the future.
Yeah. And as your article, outlines, and you've outlined today during our discussion, that how important this is for the future, that we treat these patients and help them as much as we can. That comes with understanding the condition better, because, wow, I was really surprised reading your article, the mortality associated with this, the healthcare costs, how many people it affects was just very shocking to me. So, I mean, this is a really important topic, obviously, and something that we can continue to do better in. Wonderful. Well, thank you so much. It's been really great talking to you today.
Thank you, Katie. I appreciate it too.
So again, today I've been interviewing Dr. Adriana Bermeo about her article on a multidisciplinary approach to non-epileptic events, which she wrote with Dr. Victor Patron. This article appears in the most recent issue of Continuum on Epilepsy. Be sure to check out Continuum audio episodes from this and other issues. And thank you to our listeners for joining today.
This is Dr. Tishme Monteith, Associate Editor of Continuum Audio. If you've enjoyed this episode, you'll love the journal, which is full of in-depth and clinically relevant information important for neurology practitioners. Use the link in the episode notes to learn more and subscribe. AAN members, you can get CME for listening to this interview by completing the evaluation at continpub.com/audiocme. Thank you for listening to Continuum Audio.